Well, I did have 120 slides that I reduced to 12. What I'll do is I will sort of just give a few philosophical thoughts based on my presentation that I had, and really seamlessly go into the discussion. I did want to get some discussion going. And so I'll probably just show you about 3 slides, I think, from my presentation. And some of the experiences that we've had at Stanford in terms of coming up with innovative solutions for problems that are relevant to global health. Now, healthcare, as you know, is really a complex task, and the ecosystem can extend from high end to low end and everywhere. But there are 2 common sort of strategies to solve the problems related to health broadly and global health specifically. Either you can be improving the physical capacity, which means you need better equipment, and we have heard some of the examples of that, or you have improved training in order to get the healthcare personnel to be performing at an optimum level. At Stanford, we have a program, can we have the lights a little bit dim? I don't know if that's actually visible, called the Biodesign program, which actually aims at improving equipment, medical devices. And we have a new program called the SimDesign program that helps to improve the learning methods using low-cost simulations, or low-cost simulators. The Biodesign program has been around for a number of years, started by Paul Yock and others, and has been very successful, and has now extended out to other countries. So we have a Stanford India Biodesign program. We have a new program that's linking up Stanford with Singapore from this year, and we hope to go into Africa in a couple of years from now as well. The SimDesign program has already taken that on and is already developed a relationship with India in order to pick up needs from the Indian context. The thing that is common to both of these programs is an interdisciplinary approach, and you've heard that in all the talks this morning, that it is really people from different disciplines working together that is the only way that's possible to get meaningful solutions. And to put that in perspective for global health problems, it has to be couched within this framework of affordability, which increasingly is actually truly global, and it's relevant as much here as other places. Sorry about that. Let's go back. So biodesign really sits at the crossroads. MedTech is another word that's used for biodesign, as opposed to biotech, which is more in terms of pharmaceutical innovations and so on. And it really sits at the crossroads of these disciplines here, and it very much needs driven. And as you've heard earlier this morning, if you go about, and I've seen this happen many times, have a wonderful solution looking for a problem, you almost never find the problem. So you really need to start and define the problem, and that is what we do in the biodesign as well as in the SimDesign. The SimDesign is a little different from everything that you've heard this morning because it is about educating or augmenting the skills of healthcare professionals, and it's really centered here. This is the pyramid of clinical learning, as we have talked about in many other sort of fora. You take information, any healthcare provider, whether that's a medical student, nursing student during their training years, takes information, goes through the process of knowledge, skills building. Ultimately, we hope that they arrive at the stage where they have proficiency and good judgment. And it's really in the center of this pyramid that the skills training is crucial. And traditionally, it has been done in this sort of see one, do one, teach one paradigm. But that has now changed in the last sort of 10 to 15 years when simulation has now become mainstream. The problem with this simulation is that it's driven by technology and driven by industry, where the procedures that are being simulated don't necessarily have to do anything with health outcomes in the global health arena. And that's what we want to change by SimDesign. Now, when we look at innovation broadly, this is adapted from Bransford, as expertise rises, it does not necessarily mean that innovation capability will rise. And by the same token, those who are at the left end of the expertise spectrum may have a very high innovation quotient. And I think the two don't go hand in hand, and most experts sort of end up in this area, whereas what we really want is an adaptive expert. And there are many ways you can go about achieving this, and one of those ways is actually working in teams. So you take people who are at different places in this graph and you put them together, and hopefully you'll get some magic at the other end. At Stanford, what we have done is we've actually gone across campus, and this is an aerial view of the Stanford campus, and it shows how close the School of Medicine, School of Engineering, the Business School, and the Design School are, all within 10 minutes walking distance from each other, and that's really helped us to collaborate. And in both of these programs, we have fellows who go through the training program, a year or 2 years long, and a typical team of fellows would consist of a physician, an engineer, an MBA, and a design person. And that's really how they work together, and they go about together through the entire process. And these are our success stories. These are the fellows who've gone through the program. Many of them have gone on to join academics. Some of them have gone on to start their own companies and have become quite successful in their own right. And the secret magic, the secret of this process is really that it is very much needs driven. And these needs are picked up from true first-hand clinical immersion. And so all our fellows, whether they're medical or not, they go through this clinical immersion program and they come up literally with hundreds of needs that they look and observe and they think are unmet needs. And they go through a process of actually looking at these needs and then scoring them and prioritizing them based on a number of different filters and different factors that they weight differently. And as a result of that, they come up with their top needs. And their top needs are maybe 1 or 2 needs out of hundreds. And then they take those needs and they actually generate multiple concepts through a process of brainstorming that hopefully will result in multiple concepts that can give possible solutions to that 1 or 2 needs that they have come up with. And as a result of that process of brainstorming, these concepts are then screened to come up with a 1 or maybe 2 in some cases concepts that are really worth prototyping. So that's the process. It is a process that is learned, it is learnable. There is nothing truly magical about the process of innovation. It's a process that has a method to it. And all our solutions that have come out in the last 10 years have gone through this process. So let me show you an example of one of the results that we came out. This is the Stanford Jaipur knee. Many of you might know the Jaipur foot, which is an artificial prosthesis for below knee amputees, has been around for 35 years. Very low cost. It costs about $20 a piece to manufacture. But they have struggled with developing a knee that had good biomechanics in it that could be then used for above knee amputees. And most good knees, artificial knees, cost in the range of $10,000 or more. And so they approached us and we talked about this, and this was about 3 years ago. Long story short, we've come up with a knee that's cost now actually $20, is actually being manufactured in Jaipur, which is in India, and has been fitted on 1,500 patients that are walking around in India now, not a single failure so far. And I have a little video clip if this works. I don't know, is it possible to click on this video clip with your mouse at the back and make the video work? This is Kamal. He's had a above knee amputation and really struggled with walking and was fitted with one of these knees. The way it's done is that the patient comes in the morning and they go back in the afternoon with a fitted knee with their custom prosthesis, training, and everything completed. So I'm going to skip a couple of slides here actually because in the interest of time, so that we can actually get some questions going and talk a little bit about simulations just to wrap this up. This is a paradigm, the new paradigm of simulation-based training, and for those of you who are in the business of training healthcare personnels will really resonate with this. Simulation comes in between a step of the sort of textbook lecture demonstration and then the see one, do one, teach one paradigm of being able to practice straight from the textbook. And what we have done is we've taken the same innovation process and added a couple of steps on top of that. So we identify, instead of the unmet health needs, we identify the educational gaps. And this is our new program, the Sim Design program, which has been in the works for about a year now. And we also have educators, professional educationists who have PhD in education working with us, who help us in doing what is called as task analysis for the clinical task at hand, and then define the learning objectives, and based on that we then generate concepts for how best to design a simulation that really matches the learning objectives. And we're looking at very low cost type of solutions in order so that it's actually workable in resource limited settings. And this graph really talks about what is the traditional form of simulation and what I call the sim-sim paradigm. The first sim is for simple and the second sim is for simulation. And simple simulation doesn't have anything to do with it being low-tech or high-tech. It is truly what it is. It is a simple simulation. It's the simplest simulation that can achieve the learning objective, whatever the cost might be. And it is driven by learning objectives. It is driven by educational needs rather than technology that might be available. Traditionally, as the complexity of the clinical task goes up, the complexity of the simulator also goes up, and that's really where you go to the traditional path of low-tech to high-tech simulators. But many simulators that are actually on the market today are addressing tasks at this end, at the left end of the spectrum, but they are fairly complex simulators, and in my opinion, they end up with a lot of unused resources within the simulator. What you really want to be doing is you want to be at the other end of the spectrum where you have complex tasks, but you can actually address the problem with a very limited or low complexity simulator, and that really will result in cost-effective solutions. And there are many examples of this that are beginning to now emerge in the literature for even high-end surgical procedures like laparoscopic skills training, and this is one of those box trainers that really achieves the same solution as something that costs 10 times as much, which is the virtual reality types of simulators. There's nothing wrong with the VR simulators, it's just that they're more expensive. And this is an example of a study that was done by UCSF at the Muhimbili University in Tanzania, where they came up with several simulators that are very low cost. The entire surgical curriculum they went through, and they came up with 7 simulators, cost less than $100 for the entire simulator development process as well as for the training. And you can see the types of the type of materials they're using in this setting, whether they're foam or plastic or rubber tubings. In most cases, very, very simple, very easily, readily available materials that can really be produced on site and can be used for the purpose of skills training. And what we're doing is we're taking these as an inspiration and taking our success stories with the Stanford Jaipur Knee Project, and we're now working with the World Health Organization. The WHO has a very large program called the Global Initiative for Emergency and Essential Surgical Care. And they have come up with this curriculum over the last 4 years. This 4 years of work, the curriculum is now ready, that talks about the surgical care at the district hospitals. And there are about 200 different skill sets that they advocate that every healthcare professional should be proficient in wherever they might be. And every individual, every patient should have access to this type of surgical care. So what we're doing is we're taking that list of skills and prioritizing from that list and going down that list and coming up with simulators that address the content material that goes with the teaching. Okay, I'm going to stop there. I'm going to actually invite the panel to come up to the front now, and maybe we can have the lights, and we'll have a question-answer session now. If you have questions that you